Well, thank you, everyone. Really humbled and honored to be here. Name's Manik. I'm the founder and chief strategy officer here at Healthify. Came from a background of doing community health work in East Baltimore for a number of years, which really revealed a lot of the infrastructure challenges in communities to really address social needs at scale. And at least personally to me, showed how our inability to address these needs systematically really impacts the ability for a family to thrive. So thank you everyone for joining today. I hope everyone is staying safe and healthy mentally, emotionally, and physically during this time. And to start off, I figured it'd be great to provide a framework of how we think about the big problem areas in the space, and then walk through specifically how we can help. I'm going to talk about our solution and an example for each section so folks can really tactically see how this works live. And the first starting point is what we call the social needs funnel. This is a framework to help understand what are the big pain points when we talk about social determinants, because it's really hard to know where to prioritize an individual's attention when thinking about this space, because there's so many infrastructure challenges that emerge when talking about social determinants of health. So hopefully this will be a helpful framework for folks to use going forward. So first, at the top of the funnel, there's this pain point of identifying needs and analyzing risk to build a financial case. We see a lot of state Medicaid agencies and a lot of health plans not have enough visibility in knowing in their membership who has a need, the severity of the need, and most importantly, what the impactable cost is around those interventions to help determine what the funding stream is or the intervention pathway might be down the road. And this is critical. When we think about building the financial case for these services, it's even more critical now when we're coming out of quarantining efforts. I'll talk a little bit about our work during COVID-19, but we've seen two trend lines we don't want to see. Right? We're seeing a decrease in capacity around social services, and we're seeing an increase in demand, specifically in food and childcare. And in our mind, it's really a rallying cry, not only one shining a bright light on the challenges we knew existed, but really a rallying cry for us to really think deeply around how do we build the financial case to allocate funding for community-based partners, drive capital and empowerment to community-based organizations in the field to really allow these interventions to sustain and scale. That's the big open question in the space, is sustainability and the impact on ROI. So we're going to start with a bit of how we think about analysis and building a financial case. Next, which has already been talked about from phenomenal panelist crew, is, okay, what is the network to provide these services? And there are a lot of players. This takes a village to do, and it's long-standing work that requires deep relationships. How do we have community partners, payers, providers in the public sector working together and sharing information in an accountable way and in a transparent way with aligned incentives? And I call out these three words because when we think about coordination of service delivery between healthcare and social services, accountability, transparency, and incentives are critical for one, engagement with community partners, reporting for community partners for their funding, and ultimately accountability to make sure that we're serving families the best way we can with any accountable network we structure. So that's another big pain point people struggle with, is how do you formalize these relationships? What's the level of contractual accountability? And what's the level of quality and engagement to require with a set of community partners? Next major pain point is the workflow. And as you can imagine, when we're trying to align community partners, payer and provider together, there's a ton of emergent workflow challenges that pop up. Right now, there's no standard language of how we think about social needs, let alone how we think about social service referrals and the impact of those referrals on clinical outcomes. So making sure we think through what does the workflow look like, how does that integrate with EHR, care management, HIE, and other systems is critical to success, and is another big pain point we see people struggle with. And finally is outcomes. Once we have a robust infrastructure in place to coordinate around these needs, how do we make sure that we have the right metrics in place to calculate financial and clinical ROI to make sure there's a virtuous cycle of investment around these services for long-term sustainability? So those are the four key bucket areas of pain points that we've seen over the years. And we're going to walk through each one in terms of what we do. At a high level, I know we talked briefly a little bit about technology and resonate with a lot of the comments. Technology is not a magic bullet here. This requires long, hard work and building trust. And being an ex-community health worker myself, I think CHW models are a great way to build that trust in communities. And we at Healthify, we think of ourselves as, how do we help populations by building the infrastructure to integrate social determinants into the era of value-based care, and been very lucky to work with quite a few health plans and providers and public sector agencies across the US for the past 6 years. So let's jump into the solutions themselves. So first, when we think about that first phase, how do I build a financial case? How do I know, especially when we know we can't pay for a lot of these services out of MLR, how do I think about a financial incentive for a community partner? And how do I prioritize the right interventions when I think about coordinating with a network of community partners? So what we do here is we provide an SDOH population analysis. And what this is we take in demographic and claims data from a plan, have a couple of models built on food, social isolation, housing insecurity, transportation access. Those models are built on things like car ownership records, property record values, you name it. And we spit back out, here is the cohort of members at high risk, and we can do this at a statewide level as well. And if you adjust their spend for age, gender, and clinical risk score, here's what the impactable cost would be. So now an individual has a real cost savings framework to think about this work to really enhance scalability long-term and really deploy the intervention through the entire support across the entire organization. To visualize that a bit, here's an example of some findings of looking at a health plan we worked with in the past year. So we looked at 4 different models here: stress score, housing instability, neighborhood stress, and transportation acuity. If we take housing instability, for example, we identified a very small subset of members, it's about a 100K plan, that were high housing risks that were previously not known to the specific health plan and had a 75% likelihood to move within 90 days. And then when we looked at their cost data and the differential to a like population, we saw an impactable cost of $952K, about $188 PMPM at a very small population. And now we have a really strong framework to think through if we're going to go ahead and make investments in the space or deploy a really tactical intervention model. We know where to start and we know how to focus our attention in a high quality manner as well. So that's one part. Next is a meat of our work, which is accountable networks. At a high level, what we do here is we provide access to a network of community-based agencies where we own and support the entire process of identification, evaluation, contracting, and monitoring performance of that network. And accountability is really the key part of this structure. And a lot of the health plans we work with, we also include access to their clinical partners. And there's a lot of exciting work happening right now of health plans bucketing SDOH workflows as part of their VBP structure and quality incentive structure with their provider partners that we'll happily talk about offline. But to visualize this at a high level, we can think of this network in 2 ways, right? One is what we call our in-network tier. These are community partners that have have an SLA agreement and contractual structure arranged with them to provide some level of accountability. And folks can coordinate interventions with them in real time across the network, so payer, provider, and community partner. And this allows us to provide access to a broader MSA or region to a high quality network of community partners and support the community partners as well. And I'll talk about incentives in a second. Now, where it gets interesting is we also recognize that when we think about sustainability and financial incentives, and then we look at the health plan perspective as well, it's really important to think through, how do I align this with either an existing benefit structure, or how do I align this with a higher degree of contractual accountability with a subset of community partners that I know are going to drive high impact. And we call that our preferred network, which is really health plan specific, where we go and negotiate and manage the subcontract of that relationship for that preferred portion of that network. But one can't talk about networks effectively without really deeply talking about incentives, because community partners look to the healthcare system and say, hey, great, I'm glad we're going to be integrated into the clinical delivery system, but what's in it for me? And it's really important to recognize that fact and meet folks in the middle and work with them and collaborate with community partners to drive engagement. So the different incentives for either side of the network. When we think about the broader network tier, we do a lot of things, whether it be reporting to support their existing funding streams, financial support from network conveners and foundations, access to a learning management system, and facilitated community-wide meetings. So there's quite a bit there alongside the technology they get, which I'll talk about in a second. And on the preferred network side, it's really direct financial incentives. And going back to some earlier comments, we're spending a lot of time on how do you structure this financial relationship in the appropriate way to support a cohort of members in the preferred network to make sure that the intervention is delivered in a highly accountable way to serve families and also serve the Medicaid member in the right way. And we support with a lot of components of this, along with invoicing and pass-through for a single point of entry for those preferred community partners. And I know folks are probably thinking about how do these payments work, right? And it's really the wild, wild west right now across the country. Usually participation grants are the easiest place to start to drive network engagement. We've seen case rate models and pay for success models, which are more complicated and sometimes adopted with some of the 1115 waiver programs that are out there. And this is really local market specific. So that's the network model. We support this network with an interoperable SDOH platform. Does all the things you would expect. Helps folks screen for needs, find services, coordinate referrals in a network. The main word I want to call out here is interoperability. What doesn't get integrated doesn't get used. And we've integrated a lot of the usual suspects in the EHR world, HIE and care management world. And it's deeply important to get that right. Because when you think about it from the perspective of a community partner trying to adopt a workflow around SDOH, a care manager, a call center, a community health worker, or a provider that might be deployed in an outpatient setting, integrating a robust SDOH workflow is new a lot of the time and requires a lot of heavy lifting and understanding and workflow alignment and executive alignment across those organizations to really drive a workflow that makes sense and sustains. And that really starts with integration. And that's tied to our success model. So we have a dedicated team that supports folks across the way from everything you can imagine, from implementation and partnership success. But to make this real, I want to call out a little bit of the exciting work our success team has done in this climate of COVID-19. So I talked about a little bit earlier around how the trend lines are changing. Increased demand, lower capacity. We see in our own work across the US, about 80% of community partners changing their service delivery model. And we've seen about a 2.5x increase in food demand across our networks of accountable community-based agencies. And more interestingly, what it's prompted is how is the service model going to change? So I'll call out one specific example here out in Kansas City, where there's a lot of great food banks. One, for example, Food Equality Initiative that had an excess surplus of food because they weren't delivering the food with all social distancing efforts going on, and they were a brick and mortar site. So what we were able to do with our team internally was we collaborated with them, our health plans in the region, the Rapid Response Fund, Acumen America, and brought to bear a model where we connected the food bank with a ride-sharing service to deliver 15-day meal delivery boxes to folks who are positive with COVID-19, vulnerable families, and school children who are previously receiving lunch at the school lunch program. And it's that type of innovation, when we think about long-term sustainability and recovery in a post-COVID climate, that are going to be necessary to a lot of these community-based partner models that are going to dramatically change in the new landscape over the next few months. And finally, to close off with ROI. As part of all of our work, we think this is critical. We care about the long-term sustainability of this space, and we care ultimately about how do we solve this balance, inequitable balance of capital to community partners to drive interventions for families who need it. So ROI and working collaboratively to prove it is pretty critical. And to show an example of that, here's an example of one of our ROI studies out at Reading. Here's a high-level view of the implementation. Happy to take a deep dive here, but at a high level, first couple of months, we're building the strategy of the network. Next couple of months, we actually executed the contracts with community partners, built the scorecards, evaluated the performance of these community partners, and developed a network impact report. And in total, had about 45 community partners in that region, with 13 of which were preferred across key domains, primarily in housing to support the Latino population there. And we were able to see just in the first year in a small population, 15% reduction in cost and 15% reduction in ED utilization. And I know previously it was mentioned, ED utilization is just one way of looking at this. And this was primarily due to the methodology with CMMI. But if you think about this, the ROI is there for these interventions when we think about incentive structures and governance with a network of community partners and an integration with the EHR. There's about $1 million in savings in just the first year, not looking at all the other aspects of ROI that are produced when addressing these social needs. So we're super excited about this work. And I just want to thank everyone again. That was the crux of what I wanted to share today, from building the financial case, aligning the network with new delivery models, driving real contractual accountability, supporting with technology, and then ultimately proving ROI to make sure these programs sustain in communities and the stability that communities need now and in the future are there. So with that, I'll pause and would love to take any questions.
Thank you, Manik. That's been great information and really sort of thoughtful presentation with regard to your approach. I know we only have a couple minutes, so I think one question we have is I think you spoke to sort of the layers of efforts that need to come to play to build out these relationships, particularly with the accountable networks. I'm curious if you're starting to see these opportunities to really scale and sort of streamline what your model over time, just given your experience working with health plans and providers, whether there's any sort of nuggets of learnings you want to share with regard to how this can be accelerated, just given the current environment and the need to kind of do things more quickly and more broadly.
Yeah, no, absolutely. So I feel fundamentally that the scalability with community partners is a matter of incentives and governance. And the clearer those incentives are, the higher the engagement, the higher the scalability, the quicker the speed to market. And we have the scar tissue to show that if the incentives aren't there and visible, engagement really dwindles off after the first 6 months to a year. So in this environment where we know health plans are thinking about spend, especially over the past few months with some level of uncompensated care, I think there's a great opportunity to say, hey, let's make the investment to drive incentive and financial incentive structures with community partners in a sustainable way that really drives scalability that makes sense. I think the other big learning is making sure community partners in the conversation from day one. It's not enough to say, here is the platform for the team to use. They need to think of this as a collaborative effort, that they're in it and supporting their community, because that's what makes it mission aligned to them and makes it aligned with the existing funding streams they're already receiving if the funding stream from the health plan or the state is not there just yet. So it's really, how do you build that trust and collaborative relationship alongside the incentive structure to make sure that it's an equitable relationship across all parties to drive scale.
Great, thanks so much.